art picture. Ladies and gentlemen, it gives me great pleasure to open our second neuroendocrine Q&A session. We've had a wonderful session last year. Hope this will emulate it or even improve it. We've got a number of wonderful doctors involved in the care of NET patients who are here to ask any and all of your questions. You can see there's two main contributors. One is Sydney Vital, that's what I'm directing, and Sydney Vital is a translational cancer research center, meaning it's a center that hopes to facilitate evidence that comes from the bench and goes to the bedside to your treatment as fast and as well done as possible. We fund it through Cancer Institute New South Wales, so Ministry of Health, and we're on a 5-year funding round. So we're in our 4th year of funding, and what we've decided is to fund a number of translational centers of clinical excellence, and one of them at North Shore is neuroendocrine tumors. And for that we fund not only the contributors to leading that flagship, but we also fund a PhD student who will do some basically and very well needed research in neuroendocrine tumors. And we do it in combination with Unicorn Foundation, as you all know, the foundation that has really took it upon themselves to improve the outcomes for you and your families. So I'm thrilled that you're here in big numbers, and I hope it'll be a great evening of some good, if you like, collaborative work and thinking and answers to any of the questions you might have. So I'd like to introduce Nick Pavlankis, medical oncologist, who will be the MC for tonight.
Thank you, Alexander, and firstly, thank you all for coming this evening, and we hope that we can be useful to you and to your family members. I'd like to first introduce the panel, which we'll go through systematically. One of the things I wanted to do that, one of the reasons I wanted to do that is because neuroendocrine tumors are a complex disease. Many of you probably have realized that. And consequently, there is no one expert in the disease, and we in this hospital have set up a multidisciplinary team that reviews cases and provides advice and information back to the doctor that's leading the case to then discuss with you. And we want to give you a case example during this session to demonstrate to you how we do that in a snapshot sort of way. We actually have also the person whose case is that is on the panel today, and we'll hear from her, I guess, a little bit about her story and how we've been helpful to her, and also how she's perceived the way we undertake our management here. One of the things I'll start by saying, I'm a medical oncologist, which means I look after patients with medical therapy. I got involved with neuroendocrine tumors because I had an individual patient that when I first started consulting many years ago, at a time that I had just done some research in an area that was contributing or associated with this particular disease, and my interest then grew out of that. And that particular patient, I do remember fondly. She was also inspirational in bringing some of the Unicorn Foundation to this institution. Unfortunately, she's since passed away, but I do remember her, the value that she brought to the community and with this disease. Now I chair the multidisciplinary team meeting, which we host every 2 weeks, and many of the doctors on this panel are a part of that. So I'd like to pass on to Professor Roach here and ask him and ask everyone on the panel what led them to pursue an interest in neuroendocrine tumors, or why are they here?
Thanks, Nick. I'm here because you told me I had to be here. So I'm Paul Roach. I'm the head of nuclear medicine here at Royal North Shore and clinical director of nuclear medicine in Sydney. So the neuroendocrine tumors, as you know, this is a centre of excellence in our mind for neuroendocrine patients, and a lot of patients with this will end up in my department. And so a lot of people have had scans, and I'm sure a lot of you in the room have been in the department and had PET scans. I'll be telling you a little bit more about those, or explaining them a little bit more. But the other thing, of course, with this is it's not just the diagnostics, but the therapeutics. And lutein therapy is also conducted in nuclear medicines. This is one of the few specialties, I guess, that I deal with in the hospital, where we do a lot of diagnostic work, but we also do quite a lot of therapeutic work. So it's particularly interesting. Obviously, as head of department, we have a fairly big team that are involved in different aspects of research. And the other thing I've sort of also got very involved in is the government side of things. So as I sat with John Lydon down there with various difficult people in the Ministry of Health talking about funding lutein, and more recently dealing with similarly difficult people in Canberra talking about the funding of dotatate scans, I've got to see some of the political side of this as well. So various facets of the disease.
Thank you. And Alexander? Well, you've already told us who you are. Alexander, by the way, is our Chief Representative Surgeon in the multidisciplinary team meeting, as well as leading the Sydney Vital.
There is an anecdote why I became a surgeon and not a nuclear.
Too tall.
Now, when I was a student in the Netherlands, and I took a 4 weeks nuclear imaging because I thought that is the future. And then they showed me this scan. It was actually all the carcinoid, so neuroendocrine, then carcinoid patient. I said, and we're very enthusiastic about the location of the tumor. And I went, I'm not sure about this. This is 30 years ago. Now you can see that the tremendous development we've made in functional imaging of neuroendocrine disease, where we can actually pinpoint to the exact almost half centimeter where the tumor is and how active and what sort of activity it has. But I wanted something more hands-on, so that's why I became a surgeon.
Thanks. I'm Mustafa Castro, medical oncologist, and I got interested in neuroendocrine tumors when I was a trainee here at Royal North Shore more than 10 years ago. So I guess Nick was my boss back then. And we had a number of complex and interesting patients that got me interested. And then when I completed my training and went overseas and came back, I applied for a scholarship through the Unicorn Foundation. And then I used that to do some neuroendocrine tumor research. And then the Unicorn Foundation helped me to do some other trial work that led to a large randomized clinical trial done through the AGITG, the National Collaborative Group for Gastrointestinal Cancer Trials. And I'm the chair of that study that's open nationally at 16 different cancer centers. And I work here as a medical oncologist. Thank you.
I'm Dr. John Parikh. I'm a general practitioner at Normanhurst in Sydney's Upper North Shore near Hornsby. And as we all know, I'm a doctor of primary contact or first contact. I'm supposed to know a bit of everything and nothing extraordinary about anything, just a doctor of primary contact. And I got involved because I'm a member of the Educational Advisory Committee at the Public Health Network. And they just said that we want some GP who can come here. I said, all right, neuroendocrine tumor. I must say that this is the term which I haven't heard for a long time or probably never. And then they asked me, do I have any cases? I said, look, I can't think of anything, but I'll still come if you want me to come. And then, of course, then I did some research to find out neuroendocrine tumor. And then I realized that this involves your gastrointestinal tract, your respiratory tract, your pancreas, and your thyroid. And we see patients like this all the time, except that I never heard of this particular term, but that is quite normal. At my level, you heard of all the different things. So, but I made it a point to come just to see all of you and see all these very senior colleagues of mine sitting around me. And as it happens, I'm always running late. And today I was running late because I usually come by train because it's so convenient. And it's a good exercise from the station to here. So it serves two purposes. And I just thought that, yes, I think I can definitely contribute after reading about this from the Googles and things like that. And I'm quite sure that we'll have a good time, and hopefully I can answer all your queries to the best of my knowledge. And thanks for the opportunity for being here.
I'm John Lydon, and my first experience with neuroendocrine tumours was in a textbook at med school. And then the second experience was when my late sister Kate was diagnosed with metastatic pancreatic neuroendocrine cancer on the background of another sibling with an equally rare neuroendocrine-like disease called von Hippel-Lindau, which we were managing at the time. We lost Kate, and my sister Simone Lydon, who's the Chief Executive Officer of the Unicorn Foundation, founded the Unicorn Foundation, not a zebra foundation or anything like that, back in 2009. And since then, I guess it's history. We've worked terribly hard to create a presence and a space for our patients, because we know when Kate was alive, we had to take her to Schellerberg, Richard, no, in New York, he's passed now. Dick. Anyway, a New York specialist, and we went, well, she was being managed at Peter MacCallum, but back then we were only at the edge of our knowledge and getting people together. So fortunately, we have galvanised and created a space for fabulous physicians and surgeons and allied health members here in Australia who work collaboratively. And we're hoping to create that space for our patients so that no longer are you feeling marginalised, but you have somewhere to go to. And we've got a long way to go, but I think we're doing very well.
Hi, I'm Meredith Cummins. I'm an oncology nurse by background. I think my first carcinoid patient was in the 90s. Excuse me. And I've been involved with oncology services for many, many years. I was in regional areas, which is where the first carcinoid patient I looked after was there. In the past 15 years, I've been in private practice as the Director of Nursing with one of the facilities being the Northern Cancer Institute here at St Leonard's and at Frenchs Forest and Southside Cancer Care Centre. A year ago, I left there. I took some time off. I've done a lot of work with neuroendocrine cancer through advisory councils and boards internationally, and it's been a great interest of mine. And then luckily in February, I joined the Unicorn Foundation as their project officer. So I feel very privileged to be working alongside all the people at the Unicorn Foundation. That's 4 of us, and that's nationally, but there's so much that we're doing and there's so much to be done, and I'm just very excited about being part of it. And also, that wasn't me. And just so pleased to see so many people here in the audience.
My name's Katie Golden. I'm a patient diagnosed in the end of 2010, beginning of 2011. Until that point, I had absolutely no interest in this disease. So it's per chance I now do. And I've been quite an active contributor to the Unicorn Foundation, a volunteer. I tend to put my hand up for lots of things. I help run the Sydney support group for the Unicorn Foundation, and when I look around the room, there's so many people here that I sort of now call friends, so which is not a good thing, but it's a good thing. But yes, I do what I can to help, and hopefully you can learn something tonight from all of the images they're going to put up of my complex case.
So there you have your panel. We've got a number of questions that have been posed already, and I thought one is fitting to introduce the theme. The topics that we hope that we can address for you is around diagnosis, therapy, living with a disease, engagement of the GP, and also looking at how we can improve resources and funding to do more research to make outcomes better. The first question I got here, and I'll open it to the floor after this, is taken from Tamana, and it says, how common is nits? Who are generally affected? What can be done to prevent or early diagnose nits, and what treatment modalities are available? That's pretty broad. But I thought we might start with how common it is. I don't have the actual incidence figures in my head, but I will say to you, it's not a common disease in the way that we look at breast cancer, prostate cancer, colon cancer, etc. If you look at the list of incidents, it's actually quite low down. But it is gradually increasing, and it's been well documented in US studies and other population studies to be gradually increasing. The other thing about it is not the new cases, but the number of cases in total. So the compounding effect, like compound interest. Because it is the nature of its disease, the success of some of the therapies, and what we hope is that people are living longer with this disease. The number of patients we have now is exponentially rising through that compounding effect, and that's called prevalence. And it's actually more prevalent than many of the other diseases that are more common in occurrence. And that's a very important fact, and it also affects a lot more people in the community, because as many of you may be patients here, you're people who are working, functioning, have families, etc. So the impact on the community and the burden to the community as a whole is far greater than many of the other more common diseases by the number of cases. So that's, I thought, a little bit of an introduction into the disease. But I'll open the floor to some questions here now, and we've got some others that we will address as we go along, and then Paul will interrupt it at a time that perhaps we get to a question around imaging and use it as the opportunity to look at the case. So does anyone have a question they'd first like to, they've kept up and they want to ask?
Nick, you said that it's more prevalent now. Could it just be that medical professionals are more aware?
So
and that's why it's being picked up?
Yeah, one of the first things that people ask when you actually see that are rising is, so it's actually getting more common, so the incidence is rising, but the prevalence is greater because you've got a compounding effect for better survival. That's not to say that people don't die of this disease. It's to say that compared to other tumor types, if you look at pancreas, gastric, and even colorectal, the prevalent people living with the disease is what I'm talking about, is actually much higher. So to your point, when we first saw the incidence rising, people were thinking, is it because we're getting better at the diagnosis and are we looking for it more? And there is an element of truth in that. Pathologists, for example, are better at classifying it. Our diagnostic tests are better at it. But even despite those two things, there's still a long lag time, and you might hear that from others on the panel, between onset of symptoms and the time to diagnosis. And that's because the symptoms can be so vague in the beginning with some patients. And there is no screening tool that you could do that universally will search for this disease. Although you could argue that the gallium scans might show you are quite good. They're not applied in the screening sense.
Nick, could you please give us an update on how the clinical trials are going?
I might pass that one on to Mustafa if you'd like. He's actually leading one of the national trials. I'm doing another one, but perhaps just to give someone else a chance on the panel. Mustafa, I can answer.
Yeah, that's very generous. Thank you. So I guess before we say that, we have to understand that nets are not one disease. So that there are the grades 1, 2, and 3. And a grade 1 net is very different from grade 3 and grade 2s in the middle. But even the grade 3s can be divided into two subsets, the extremely high grade and aggressive, and those who are not as aggressive. So the trials will also be built on the basis of the grading. So in the grade 1 and grade 2 tumors, there have been, well, like when I first started getting involved with this disease, there wasn't much in the way of high quality, large sample size clinical trials. But in the last 10 years, we have seen a number of large international multi-center randomized trials of high quality that confirmed the efficacy of a number of treatments, including PRRT, so lutate, but also chemotherapy and targeted therapy with that two drugs that are proven to benefit patients with grade 1 and 2, especially in the pancreatic primaries. One of them is called Sutent, the other one is called Afinitor. But the grade 3 is more difficult to study because it's less common and the patients have more aggressive disease. So I guess there is a significant amount of work that has been done to confirm the value of certain treatment, but there is a much bigger gap that need to be filled with more trials in the future. And there are more studies ongoing here in the country. So Nick Pavlakis has led a national study comparing chemotherapy with lutate and different formulations. That study has been a tremendous national effort because of a lot of challenges doing a clinical trial in a rare disease. We are doing the NABNEC study in high-grade tumors. That's again a big challenge because often patients, when they're diagnosed, they're not directed to the trial, but they're directed down the wrong path to have treatments that are not effective. And we have to work together, all of us, to encourage patients to participate in clinical trials. And that, I think, it's a good way to pass on the microphone to the gentleman sitting next to me, because in general practice plays an important role here. And many of these patients, when they're diagnosed, they're not directed to the right pathway. So my question, okay, I think John likes to comment on that. Thank you.
I will take that. Thanks, Mustafa. But it is true. The Unicorn Foundation often sees patients after their first diagnosis, or when I say sees, hears from them through our net nurse, through Meredith, approaching Simone directly, and we're able to direct you to the centres of excellence. The biggest key for uncommon or rare cancers is finding the right person very, very early in your treatment. It is golden, and I implore all of you out there to tell your friends, family members, anyone, if you're not comfortable, get a second opinion. Go to somewhere where you can be directed to a knowledgeable person, particularly in rare cancers, who can say there is a trial. We need trial participants. It doesn't mean you're getting an excellent standard of care. We were just discussing earlier, we know a number of patients who have come to us, we've directed them to trials, and in the interim they're given something else by a well-meaning oncologist or someone who doesn't have the expertise. Now that sets that person back in their treatment pathway. And so it's very frustrating because we are a rare, uncommon group of tumours. We are all individuals and behave differently. So, but on the flip side, which is contrary to what everyone believes, you do have some time. We're not talking you need to get to surgery the next day after diagnosis, or you have a little bit of time to seek that referral to the centre of excellence, and that's where the treatment should start, and then you can go back to your regular oncologist or what have you. But you do have a window of opportunity. You're coping with a diagnosis which has been catastrophic or changed your life overnight, but take a deep breath and Google. Have a look, where should I go next? Don't just accept the one bit of advice, particularly if it's outside a centre of excellence, Peter MacCallum, Royal Brisbane, Royal North Shore, and if your oncologist or GP gets a bit shirty, well, they're not worth going to. They should say, well, I'm not. I'm maybe out of my depth. Yes, go. You can always come back. It has to be, and it's very important. We see too many patients miss vital opportunities to access a clinical trial or a pathway suited to them. So keep that in mind. It is your body. You are a health consumer. You need to seek best pathway initially, and you've got a little bit of time.
Just wanted to ask Dr. Pack what he thinks we should do, or the community should do, to improve the way GPs deal with rare cancers in general.
I think we are the doctor of primary contact, and that's probably why I'm here. But I think the main thing is that there are many instances where patient will come and say that you find, say you got thyroid medullary cancer or something like that, which is a part of this one. Until I came today and I found out a bit more about it. But same thing, patient comes, they complain of symptoms related to this. You get them some blood tests done, you get that imaging done, and then you refer the people to appropriate specialist. And of course, when this happens, the second opinion is very important. But most of the time, at least in my opinion, most of the patients so far have been very well managed. They've been referred to other doctors and other people, and they usually end up going everywhere. But generally, most doctors will be sort of coordinating the things very well and work together to achieve the best possible outcome for everybody.
Thank you for that. So go ahead.
The Unicorn Foundation.
the Unicorn Foundation, one of our projects that we're actually doing is surveying GPs who are actually looking after their patients to find out what information they want to get, because we thought it's better to find out from them what the gaps are when they're actually looking after the patient. So that's actually a national survey that we're going to be putting out in the next couple of weeks. And a lot of our patients have come forward, they've spoken to their GPs, and their GPs have been happy to be contacted, so we will be sending that out to them. After we've collated the information from that, we will then go to all the health networks and put it out to all the GPs, so that we can look at modules that we can actually put together on the various diagnosis, treatment, living with nits, all the aspects of it, so that we can get the information out there, so it's not